honor to host a distinguished panel today to talk about where we've been in HIV, how far we've come, and the challenges that lie ahead. So I just wanted to start by giving a little bit of a history of HIV, just to think about really at this moment, 40 years in, what has happened in those years. So in 1981, some of you may not have been born yet, cases of a rare lung infection called pneumocystis carinii pneumonia, or PCP, were found in 5 young, previously healthy gay men in Los Angeles. At the same time, there were reports of a group of men in New York and California with an unusually aggressive cancer named Kaposi sarcoma. By the end of 1981, there were 270 cases of severe immunodeficiency among gay men, and 121 of them had died. Fast forward to 1990, between 8 and 10 million people were thought to be living with HIV worldwide. And Ryan White died of an AIDS-related illness at the age of 18. Some of you may know the Ryan White program that funds HIV care and treatment here in the US in honor of him. It wasn't until 1992, nearly 10 years after the first cases of HIV, that the FDA licensed a 10-minute testing kit, which could be used by healthcare providers to detect HIV-1. And in 1995, almost 15 years later, the FDA approved the first protease inhibitor, beginning a new era of highly active antiretroviral treatment, which is still used today. It brought about an immediate decline between 60 and 80% in AIDS-related deaths and hospitalization, but it took 15 years to get there. And it was only available in those countries which could afford it. By the end of 1996, the estimated number of people living with HIV globally was 23 million. In 2002, UNAIDS reported that AIDS was by far the leading cause of death in sub-Saharan Africa, the leading cause of death. And in 2005, AIDS-related deaths peaked globally at 2.8 million deaths per year. However, with advocacy, financial support, and reduction in costs for ART and treatment became more widely available. By 2013, AIDS-related deaths had fallen 30% since their peak in 2005. Fast forward to nearly today. In 2019, 38 million people were living with HIV. Of those, 25.4 million people are now on treatment. I think that number is staggering, and it's a number that my 2005 self, who started work in HIV research, wouldn't have believed. However, new HIV infections have also been reduced globally by 23% since 2010. But in 2019, there were still 690,000 AIDS-related deaths globally and 1.7 million new infections. The UN did not meet its 2020 target of reducing AIDS-related deaths to fewer than 500,000. And in the US, in 2019, 36,800 people received an HIV diagnosis for the first time. These infections disproportionately affect people of color. Black and African American people in the US accounted for 42% of these diagnoses, and Hispanic Latino people accounted for 29% of these diagnoses. The US has launched the Ending the HIV Epidemic campaign, which aims to reduce the number of new HIV infections in the United States by 75% by 2025. But HIV is not only work and numbers, it's also personal. It's the people we love that we've lost. It's passion for equity and justice. I invite you now to close your eyes just for 30 seconds and think about your own history with HIV. Take a deep breath and just close your eyes. Thank you for doing that. Our distinguished panelists will help us reflect on our shared history, as well as what lies ahead in the HIV epidemic. I'd like to first introduce Dr. Rupali Doshi, who has her MD and MS. Dr. Doshi is the Chief of Strategic Information Division at the DC Department of Health. She also serves as an epidemiologist at the George Washington University. Her current HIV research centers on improving HIV in care and treatment and rapid ART initiation. Welcome, Dr. Doshi. Marcia Ellis, with an MA, has been involved in HIV and AIDS and health and wellness advocacy for over 20 years. Marcia serves at the DC Center for AIDS Research Community Coordinator and Chair of the Community Partnership Council. She facilitates and supports meaningful community engagement and partnerships between CFAR investigators and the DC community. Recently published an editorial in the American Journal of Public Health on HIV at 40, titled 40 Years of Fighting for Equitable Partnering in HIV Research. We are not there yet. And Dr. Audrey Pettifor, PhD, is an epidemiologist whose research focuses on sexual behavior and determinants of HIV and STI infection in sub-Saharan Africa. Her goal is to identify modifiable risk factors and develop novel interventions to prevent new HIV infections, particularly among adolescents and young women in sub-Saharan Africa, where she's led several large clinical trials. But recently, Dr. Pettifor has taken her expertise in HIV prevention and applied it to understanding COVID-19. Welcome to all our panelists. We're very excited to have you here today. And I just want to remind the audience that we will be taking questions through the Q&A button at the bottom of your screen. Please do not record the session. We're recording the session ourselves, and we will make it available. And closed captioning is available to those who need it if you need to click on it at the bottom of your screen. Okay, so I'd like to start by asking our panelists a question about successes and inspiration. What inspires you to work on HIV, and what do you think have been some of our biggest successes? So first, I'd like to start with Marcia. As an advocate, Marcia, who's worked in the movement to advocate for people living with HIV and for more than 2 decades, what drew you personally to this work? And what do you see as some of our biggest successes?
Thank you, Nina, for giving me this opportunity to speak out loud some of what I've been reflecting on during this period of the recognition of HIV at 40. Advocacy and activism have been critically important in the history of HIV, and both together have resulted in some of the many changes that we have seen over the 40 years. Without it, we would not be where we are 40 years later. I want to take this opportunity to lift high with gratitude and respect those who we lost to AIDS, those still among us today, and those who continue to carry the torch. And I want to lift up those researchers, those providers, and those friends who care for and love us through life challenges like HIV. My advocacy came out of my own personal life story and my journey with HIV. 35 of my nearly 70 years has had HIV in it. So I was compelled to do something, and then realized that there's a name for these acts, which is advocacy. I saw where I'd been involved in advocacy well before HIV as a teenager and young woman in health settings or as part of social movements and causes. In more recent years, I call those sparks to my advocacy or activism my Rosa Parks moments. Mrs. Parks said at that moment when she refused to give up her seat on the segregated bus, quote, "The time had just come when I had been pushed as far as I could stand to be pushed, I suppose. I had decided that I would have to know once and for all what rights I had as a human being and a citizen." So as a patient in a clinic where I was being treated, I was asked by one of the physicians if I'd be willing to restart their community advisory board. I agreed, despite the fact that I didn't really understand the science, because I saw in it an opportunity to educate myself, to break my own isolation by joining with others so that we could learn together, find community, if you will, and have an opportunity in a more intimate setting to interact with doctors and with researchers, and to raise questions and make input based on our own experiences with HIV and with different treatment courses. That beginning in a small group of people quickly grew to my participation in larger and more diverse community platforms involving some of the most courageous and inspiring advocates and activists locally and globally. And it brought me face to face with HIV research and researchers in ways that I never imagined that I would be. It gave me a platform for my advocacy that alongside so many others can and has made a difference. So what are some of the biggest successes in HIV's history? For me, the biggest successes in HIV history are the ones that changed lives, changed structures, changed processes, and shifted paradigms. Community took a horrific situation and organized and came out fighting. In the spirit of movements for change at other times in history, that advocacy and activism was absolutely critical to getting the kind of attention and changes needed to save and improve lives. People struggling to live with this new frightening disease demanded to be seen as humans with the rights to their sexual and overall life, to be at the tables of policy and research in AIDS treatments. In some communities, people opened their homes to provide compassionate care and love to those being literally thrown aside in many cases. Research from clinical trials that depended on the participation of those living fragile lives with HIV resulted in the discovery of different classes of drugs to outsmart the virus and relieve those affected from some of the debilitating symptoms, illnesses, and death. Lives turned around because of that research, those researchers, those providers, and those advocates, activists, and research participants. Advocacy and protests continued to grow and grew globally, and community involvement in research became a norm. Relationships between providers and patients were redefined to one of greater compassion and mutual respect. Together, they had to figure out how to make our lives better in the absence of anything else. So many retrospectives have been written in recognition of this 40-year milestone, and they all acknowledge undeniable successes, including drug development and treatment that allowed many to reach undetectable status, positive mothers able to birth healthy babies free of HIV, the PEPFAR program, sharing the successes with others in the world, the development of prevention tools like PrEP, greater investment in cure research, U equals U, undetectable equals untransmittable, and the decline in HIV diagnosis rates, and people living longer. But they also talk about the challenges, and there are many challenges still. Thank you.
Thank you, Marcia. That was eloquent overview of all those great successes, which is really amazing. Thank you for highlighting all of them. Rupali, let's switch to DC. You work with the DC Department of Health on ending the HIV epidemic here. What has inspired you to work with them, and what do you think are their biggest successes?
I'll take you back a little bit, just sort of like Marcia did. So I started working with individual patients who were diagnosed with or living with HIV. During my medical training, I was in a couple of different cities in the United States, and also had an opportunity to see people in Uganda. And I think the thing that really struck me was that despite the time that I was starting out as a trainee, we were already in 2004, 5, 6. We had a lot of amazing medications already available to us. And the patients that really stuck with me were people who still didn't seem to be benefiting from all the biomedical advances that we had. So those would be, I remember somebody who was a 32-year-old who already had advanced disease living in Atlanta, Georgia. In the United States, the wealthiest country in the world, and somehow people were still not benefiting from all of these medical advances. So I sort of pivoted to think about, well, where might be places to have an impact on the broader population and address some of these some of these challenges. And so that's sort of made me think about the world of public health to begin with and in HIV. And DC, I think, was a really interesting place because they had, they saw a problem. It was around 2006 when they diagnosed a lot of people, in the thousands with HIV. And they had to really figure out what their approach was going to be. And they took a citywide approach. And I thought that was a really unique way to think about it, because what I had seen before in other places was that things were still really being done by, this hospital clinic, that clinic, this FQHC. People were just kind of seeing people as they came to them. But I didn't have a great lens into how the thinking was at sort of a citywide level. I think in DC, they have had some tremendous successes in the last 10 to 15 years. One big one was the transition to name-based surveillance reporting, which really helped the city get a much better accurate count of how many people were being diagnosed and living with HIV. That sort of spurred the citywide testing initiative, and also an emphasis on linkage to care and treatment through the Red Carpet program, which began around 2008. They've also had a tremendous impact on reducing perinatal transmission through their perinatal sort of identification program and case management program. And then more recently, they've promoted PrEP, they've promoted rapid ART, they've promoted them amongst the providers who are all spread out across the city, but also demonstrated how they can work through the Health and Wellness Center, as well as embracing the U equals U message for both, individual health benefits as well as reducing transmission, and also to help reduce stigma. So I sort of see those as what have been some of the major successes in DC.
Great, thank you. And thanks for talking about your personal history as well as what happened in DC. I think that's really helpful for contextualizing history and sort of what are still challenges, but also what has changed since you first entered. Audrey, you've led some of the largest clinical trials in South Africa on HIV, and recently you've shifted to COVID-19 epi research. So can you talk a little bit about that shift, what made you shift, and what lessons you feel like you learned from HIV that you've now applied to COVID-19?
Yeah, thanks, Nina. So, I guess I was sitting in Cape Town, South Africa in February of 2020 when talking about adolescents and HIV with partners from across the region, successes and implementation and working with HIV prevention with young people. And we were all talking about COVID, and I think there was some anxiety for many of us having gotten on that plane to be there. I think Nina, I think Nina was there as well. Nobody, I think at that point really could have foreseen what was to come. But, I think fast forward and people working in global health, which is where I sit, working in HIV prevention in sub-Saharan Africa predominantly, we're not traveling. I was luckily not in a position where I had any studies in the field at the moment, which was a huge challenge as countries were on lockdown and research was disrupted. But I was trying to think about where I fit and what I was going to be doing. And I think as many public health, particularly infectious disease epidemiologists and even non-infectious disease epidemiologists have found in the last 18 months, that this overwhelming need and response for COVID emerged. And here at the University of North Carolina, there were a lot of questions about the safety of bringing people back to campus. What was, were we going to see infection and spread of COVID-19 on campus if we brought faculty, staff, students back? And so there was an opportunity to kind of ask these questions. And I think I was feeling at that point very, I think many of us get into public health because of the public service, and we want to do something and we want to respond. And it felt like there was this urgent need to respond, and that you could make a difference and do something quickly, And so for me, that was something very appealing about the COVID-19 response, was like, here are resources, go solve this problem. go, you know? And I think particularly, I've been working in the HIV prevention arena since sort of 1996. And I will say that I've gotten somewhat jaded, very honestly, with some of the, particularly in some of the international response as to how some of how things have been happening of late, and how much I think, to Rupali and Marcia's kind of comments of like, how do we get these effective interventions that we have actually rolled out? Like, we have these great tools, and what we really need to do is help people with uptake and dissemination, and maybe some of the more researchy questions have been answered at this point, and we need to be thinking about those challenges. So, you know, I work with young people, so being on a college campus, I was curious about things that we think about for HIV. So like, what are young people thinking about prevention and risk perception, and how are they thinking about socializing and peer norms, and how that influences their behaviors, right? I think I have seen a lot of parallels in how young people think about prevention behaviors with COVID, similarly to how they might think about, you know, testing for HIV or testing for COVID. What are those implications going to be? What is my partner? What are my friends going to think if they find out? How do I think about contact tracing? You know, what are the implications of contact tracing for me? They're different, but there are similarities, I think. Another huge one has been stigma. I think we have a lot to learn from HIV stigma and how that translates to how people have thought about COVID. Again, this idea of, I don't want to tell my friends that I have COVID because they might blame me for giving it to them. They might get angry if I talk to a contact tracer, if I share their details. That may not be seen as okay. So I think there's a lot, and actually I think the HIV field has pioneered some of this, and we need to, you know, hopefully, not all of the infectious disease folks working on this, and even non-ID people who have gotten into the COVID space, I hope that they're looking and listening, I think, to what we've learned from HIV over the years, because I think that there's a lot of important lessons learned. I think some of the community partners and transparency issues that, particularly in the space of structural barriers to access to care, to vaccine rollout, what people are calling vaccine hesitancy. You know, I think there's a lot to be learned from the history of HIV/AIDS, particularly in more marginalized communities and communities of color in the US, about how we approach that work, that I think is really important. So yeah, I think there's a lot of parallels, and, you know, I hope that, you know, I am drawing from that. In fact, we have adapted an HIV stigma scale to COVID. We'll see how it works, but I think there are some very similar concepts that we can learn from, and I hope that we take lessons learned and apply them as we move forward.
Yeah, thank you for those great comments. I think it's interesting too, as you said, to take lessons we've learned about stigma in particular, apply them to COVID, and also equity, just global equity, and how long it took to get HIV meds to the global South, and thinking about the current vaccine situation in the global South. There's a lot of parallels there, and a lot of people who were working on it back then are now working on it now. Yeah, great comments. So Marcia, shifting to you, let's talk now about some of the challenges. We've talked about some of the successes and what we've learned and how we've applied it to COVID. But what do you think are some of still the challenges remaining in HIV? And in particular, you focused on HIV researchers partnering equally with people living with HIV. As someone who's committed to ensuring that the rights of people living with HIV are embedded from start to finish in the research process, what do you think are the biggest challenges to inclusion?
One day it'll be automatic that you'll unmute when you start talking. In my article, I focus on equitable partnering in research and some of the barriers to it, where everyone in the partnership gets the support that they need. Though there's been some progress for sure, these I think are some of the challenges to inclusion. Intentional inclusion and shared leadership of people living with HIV and other community members in the entire research process. Lack of trust, something Audrey mentioned for COVID, that their whole COVID list could still apply to HIV still. Lack of trust in the health systems that have not served communities well and sometimes ethically. The need for more transparency and communication about what is going on in research. Inadequate resources and budgets to support true, respectful, and equitable partnerships. Stigma continues to be a huge barrier. Judgment and cultural illiteracy of communities that should be at the center of research. People and communities hardest hit too often are not seen, heard, respected, accepted, and as the research shows, hardly reached. People living with HIV and their experience are not always included as prominent voices and faces in the partnership. The problem of language that is inaccessible and stigmatizing at times. Structures and processes and organizational cultures that create barriers to meaningful and respectful inclusion. The recognition of the barriers and challenges and addressing them, addressing those barriers and challenges. Boldly confronting persistent health disparities and the social determinants of health. Lack of education and information and dissemination of findings. Really dissemination about the research process as it's going on. Critical inclusion of younger people, Audrey, so that their needs and challenges can be more effectively addressed to ensure a future without HIV. These are just some of them.
Profound list. Thank you. And I encourage you to read Marcia's editorial because it lists them all there, and it's said with much greater time than she was allowed here. But are you finished? I'm sorry, Marcia. Yes. Okay. Thank you so much for that thoughtful response. And those are indeed huge challenges. Rupali, how do you think the challenges that Marcia just touched on affect ending the HIV epidemic in DC? Are there others that you see as obstacles to that goal?
Sure. So thank you for that question. So right now, I can just give you a little bit of an overview of the Ending the Epidemic plan that DC has right now. So the plan we currently have in place is actually the second iteration. The first one was released in 2016, and it was called the 90-90-90-50 plan. And the plan was then updated and released in 2020. It was sort of planned that way and sort of nicely coincided with the national Ending the Epidemic efforts. Some of the components that are a little bit newer are an emphasis on, so the team, as they were writing the plan, actually conducted several community engagement sessions and got input from community members on how to, shift, adapt, update the Ending the Epidemic plan. And one of the things that really came through loud and clear was that, there are a lot of things that people in DC are trying to manage. HIV risk may be one of them, but there are lots of other things. So, there's things around a lot of the social determinants of health, employment, housing, economic opportunities and development in neighborhoods, violence, those sorts of things. And so whatever the gist of the recommendations was sort of like whatever the health department decides to do needs to sort of take these things into consideration. So one way we've expanded the plan is that, so there were 4 pillars, and they are the same 4 pillars of the national plan. So prevention, diagnosis, treatment, and then respond, which has a little bit more to do with sort of rapid response to outbreaks. DC added a 5th pillar, which was around engagement. And so that was one deliberate step and change that they took. They established new goals. So the goals now are 95% awareness of diagnosis, 95% in treatment, 95% virally suppressed. Those align with the UNAIDS goals. and 130 new HIV diagnoses by 2030, which is in alignment with the national EHE plan goals, basically for the whole country. So one of the things, based on some of the feedback from community members, was that they've added what we're calling a wellness initiative, and they're right now piloting it with a few organizations, and that would include things like more holistic services that's a bit broader than just the traditional view of like mental health care. So things like meditation or yoga or spirituality practices. And if you want more information, I can certainly share that in terms of what exactly might be included in a wellness program. But it's, you know, people don't always necessarily see themselves as having a mental health problem, but they may feel like, oh, well, I would, yeah, sure, I'll talk to someone about stress, you know, and there's a lot of different ways to think about that. So sort of expanding upon that based on community feedback. And then, you know, still maintaining the biomedical approaches and expanding those. So those, you know, still include PrEP, U=U, as well as antiretroviral therapy for people who are newly diagnosed. I think some of the challenges are that in the last year and a half, COVID-19 has really been on the front burner for many people, you know, most of the world, I would guess. And actually internally at the health department, probably I would estimate at least half of our staff was reassigned for working on COVID. So staffing here was also changing a lot in last year. Many of the folks have sort of come back to work on HIV and STDs, but it's still a little bit of a work in progress. I think some of the other challenges really include sort of, we don't have like a one size fits all strategy. It's really that's not going to work right now. There are populations very disproportionately impacted by HIV, and it's not uniform across the city. So what does that communication look like? What does the public health messaging look like for both not stigmatizing populations, but also being a little bit more transparent and accurate with what risks may exist for people? I think that's really kind of a huge challenge. And then sort of addressing social determinants of health, you know, that is also another huge area. We saw it with COVID. We saw the huge disparities in hospitalizations and deaths for COVID based on all these same indicators. And we've known about them for a long time in HIV. And so I think continuing to keep those on the front burner is another challenge.
Thank you, Rupali. Yeah, picking up on that, I think you hit on an important point about how the COVID pandemic is impacting the HIV epidemic. So I'd love for Audrey to talk about that and you know, what do you think are our biggest challenges for simultaneously facing two pandemics?
Yeah, I mean, I think for me, the answer here and like the biggest challenge has been, you know, how much our public health and healthcare system is just fractured and broken in the United States. And, you know, as someone who has really focused on sort of social determinants and structural determinants of risk and access to care in HIV, you know, we see the same thing in COVID, right? And I think that, you know, that to me is a huge issue. And it's not just disruptions in HIV and vice versa. It's also, you know, it's cardiovascular health, it's, you know, maternal and child health, like all, you know, I think as somebody who is passionate about social determinants, it just drives me insane because I wish if we could go upstream, we would address so many of these health outcomes, not just HIV, not just COVID, you know, things that I think, you know, Rupali was talking about, but I agree, like these structural challenges of stable housing, of work and unemployment, like, you know, we see that, you know, HIV AIDS is not your biggest concern when you're worrying about where's your safe housing? How are you putting food on the table tomorrow? And it's the same for COVID-19, you know, it's not your biggest concern. Or you're telling me I need to stay home or social distance or do these things. And yet, like, I have to be, at work to put food on the table and be placed at risk. And who's taking care of my children while I'm doing that, while schools are closed. And so I feel like there are those similar dual pandemics, and that, the really big thing here is addressing structural challenges. I have, mental health, violence, substance use, as you were saying, all of those things. I was going through my list of, what is similar between these epidemics, pandemics that we face. And I think they, for me, those are the biggest, hardest things that we need, challenges that we need to really address, not just like, here's the vaccine. I mean, the vaccine is amazing. ARTs they are amazing treatments that we have, or preventative therapies that we have. But unless we address some of these bigger issues, for a lot of the most marginalized populations, they are not going to benefit from those. And I think particularly to your point earlier, Nina, about global equity, I think we've seen that, at least, especially with COVID and, new variants of concern, that, if we, until the most marginalized can also, come along with us, we're going to be living in this space of resurgences of new variants, of, COVID not going away. We really have to take care of everybody. And I know that feels daunting, but I think, and as we learned with ART, as you said, I remember when that was like not even something people were even thinking about, that treatment for all was like, there's no way that we could think about that. So I think we have to shift our headspace to say, these are things we can do if there's global commitment to do them. And I think particularly in the US, some of this rethinking about healthcare access. I think that the living wage and the COVID stimulus type of payments are really, really important for families to be able to not worry about, can I pay my electric bill? Can I put food on the table? But rather focus on keeping themselves and their families healthy. And I think the same is true for HIV and other health and other diseases and just general well-being of people.
Yeah, I just hope on the global equity front, it doesn't take 15 years the way it did with HIV. Like, you just hope that we learn some lessons there. Well, this has been great. And we've talked about some really heavy things: stigma, inclusion, social determinants of health, structural systems like healthcare systems and how they affect both pandemics. But if we could maybe end on a hopeful note, what makes you feel hopeful about the movement to end HIV? And how can we use maybe this moment in COVID-19 to make things better and help people who are struggling even before this current pandemic, right? And really focus on equity and inclusion. So it could be a personal example, it could be something you're working on, whatever you find hope in. And anyone can start.
So I'll start. So, and I like that you use the word movement, because that is what it is, and still must be, actually. HIV is still here, and we must act like it is. You wouldn't know it in many of our communities today, and it is not their fault. So I like to, as a hopeful image for me, some of you may be familiar with the Adinkra symbol, Sankofa. Sankofa means, it's from the Akan people of Ghana, and it means learn from the past. If you can imagine a bird, this is what the symbol looks like: a bird with its feet facing forward, but neck turned to the back. In its mouth is an egg. The Sankofa bird reminds us that we must continue to move forward as we remember our past. At the same time, we plant seeds for the future generations that come after us. The seed is symbolized by the egg. That image makes me hopeful, and it applies to COVID. Use the lessons from the past. Also, I'm hopeful because there's greater recognition that while the biomedical advances have been amazing, it is clearly not the only answer. If it were, we would not be sitting here today talking about these. As mentioned by my two co-panelists, addressing health disparities and equities would give me hope, and that we know what's being done in addressing inequities and disparities, and that we can see, progress on that front. That would give me hope. Beginning to focus on, understand, and plan for the needs of those who are long-term survivors and those aging with HIV would instill hope in the human spirit. Greater inclusion of people living with HIV and other community members in research throughout the process would help us to get closer to the solutions we're seeking. I would feel much more hopeful to see more of that. Much can be drawn from COVID, from HIV that resonates with what's being experienced with COVID. Similar issues, challenges, and strategies. I mean, Audrey, I think you laid those out very clearly. I mean, that we can draw a lot from that, but they are still different. But I think one of the things that resonates with me with what you said is that oftentimes we may think that these huge things that we're facing are the most important things for us at a given moment, and there are other important things, and we need to accept that and deal with them. So I'm more hopeful about a possible HIV vaccine with lessons from COVID. And I see there's movement afoot on that front, and perhaps I'm hopeful that new advocacy and activism will help speed that up. I am very hopeful about the new leadership, the younger ones, their ideals and their activism. I mean, I am floored and really inspired and energized when I see the younger people in their platforms doing things their way, but certainly getting attention and moving things, very eloquently, very passionately. I mean, that gives me a lot of hope to see that. And I would say that being involved with the CFAR over the past 15 or so years, that I see that researchers and site leadership are beginning to get it. And how important it is to invest in communities' involvement in research, that we are valuable partners in that research. And that's being demonstrated. I've seen that over time, how that happens. And so that makes me very hopeful, because when those things are institutionalized, made, systematic, put in your structures and processes, then there's more hope that some of these things will continue. That we'll see, community partnering with government, partnering with academia, so that we can move these agendas forward. So, I wanted to kind of end with a quote, actually, that I came across my desk just yesterday. It was a quote from Paul Kawata from NMAC. I don't know if you get his newsletters. NMAC, for those who don't know, is an organization, it's an advocacy organization, a national advocacy organization, and each year they have a conference on HIV, and it's one that I really respect. But he said, and it just so resonates, and I quote, "COVID has made us insane." And I think it is a catalyst for this paradigm shift. The virus had made us rethink everything. COVID, Black Lives Matter, the January 6th insurrection, and climate change has forced a reckoning. I think what we're seeing at the border also does that. We can probably end the HIV epidemic in the white community by 2030, but if we stay on the same course, I, in the words of Paul Kawata, have real doubts about ending HIV in communities of color. That is my pledge to the HIV movement. What is fair cannot be based on white privilege. He makes a whole argument in his statement about white privilege. Our work must embrace the challenges of what is fair to communities who have lived under generations of discrimination and oppression. This is bigger than change. It is a shift in the paradigm. Ending the HIV epidemic in America starts by relooking at what is fair. So I'm most hopeful by a possible paradigm shift. I think this is a moment of reckoning, and I think we should seize it, and I would feel very happy if I saw that we were doing that. Thanks.
Marcia, those are like amazing words. I'm going to just jump in, Nina. Sorry, because I was like,
no, please.
I said yes and yes.
Yeah.
And I agree totally. Like that, I think, is what gives me hope, is the moment of reckoning. I really hope it is. I really hope it is a chance for us to rethink and do things differently in this profound shift and impact that has globally impacted so many of us. And I also get hope from the young people we work with. We've been doing a study in Cape Town, South Africa, with youth living with HIV around how COVID has impacted their HIV care. And surprisingly, and I mean, it's early days, very preliminary, but some of them are doing better in coping with COVID than their non-HIV positive peers. And I kind of wonder, these are kids in care and in a good clinical space, but part of me wonders, is that because of the work we've done, with these youth, and that they kind of have gotten coping skills that maybe kids in more marginalized settings that haven't been in care and haven't had kind of support groups have not had. So it does make me think again about like the lessons learned from HIV and how we can translate that to other settings, and for other marginalized youth, even if they're not at risk or living with HIV, like, are there things about mental health and about peer support and parental engagement and things that we know that can translate. So I'm optimistic as well that we can take lessons learned. And I agree. I think, Nina, to your point about 15 years, will it be that long? We're not where I would like to see us with health disparities and racial injustice and healthcare outcomes in the US. But I do think the conversation, the fact that it came about so quickly, that county health departments had health disparity metrics for COVID, not all of them, but a lot of them very quickly. It's hard for me to go back, but I feel like 15 or 20 years ago, I don't think that was the case. So the next place is, yes, we need the interventions to address that, but I am inspired by the healthcare providers and the community organizations out there, with their mobile vans, going out to the farm worker communities in North Carolina, vaccinating, undocumented immigrants and trying to provide confidential services and working with community partners to address vaccine concerns and increase access. And I think I see those as models, a lot of those models from HIV. And so I hope that we can continue to scale and replicate those success models throughout the US.
Thank you both. Those are really moving comments. So I'll start with how I feel using COVID-19 can help us move the EHE efforts forward. I think a lot of the different ways that healthcare engagement happened during the pandemic, particularly telehealth, video, telephone appointments, I honestly think that has revolutionized healthcare. And I know it's not perfect, and I know there's still the digital divide, and it's not going to work for everybody, but for the people who've benefited from it, it has been a huge welcome addition to their life. I have a lot of patients who are like, I can't find time in my work week to come to see you. So then they just don't come. But if it's just a telephone appointment, they're like, oh yeah, I can squeeze you in on my break. Like, that's fine. So, I think it's really added to the menu of ways we can work with people in the healthcare setting. It's also expanded into non-clinical settings. So for example, case management, that doesn't need an in-person appointment, maybe, maybe that can be done over Zoom or just a telephone appointment instead of, people having to take time out of their busy lives to do yet one more appointment that maybe is, on the scale of the 15 things they have to do that day, maybe it's like number 8, I don't know. So I think that's been exciting to see, and I hope some of that still continues going forward. There's also been a lot of innovation around self-testing and walk-in testing. And I think COVID, with this idea that people could decide when to go get tested, has also then come back to HIV and the world of STD to say, oh yeah, you could just go to the LabCorp site and just request a HIV or an STD test. We don't need this whole extra healthcare apparatus around you just for you to come in and, pop in and do that really quick. So that I think is really exciting. The additional funding for public health infrastructure and the value placed on public health to me is also gives me a lot of hope that, okay, people are finally getting it, that there's a role for public health. And it's going to look different probably for each disease or condition. But there's a very critical role that we can't continue to underfund that part of our, healthcare structure. And then, I think also one of the things that we've taken from COVID-19 from HIV and into COVID-19 has been a lot of the expertise, particularly at least on the health department side, around contact tracing, partner notification, as well as like managing data. I know that sounds like a little bit dry, but to be honest, like I had somebody from the Montgomery County Health Department talking to me about how literally the first few weeks of COVID, their fax machine ran out of paper because they were getting fax after fax after fax of COVID test results, and they literally didn't know what to do with it. So, DC has like 10,000 chlamydia cases. We've figured out how to manage thousands and thousands of pieces of data and put them into a system and like figure out how to make it work. And so some of that I think was also, it was nice to see some of that translated into the world of COVID, at least at the health department side. I think people are still dedicated in the world of HIV and STD. At the health department level, the local clinics, the community-based organizations, the advocacy groups, everyone who has been working on these conditions for a while still is dedicated. We took a little detour with COVID, but we're still here. And I also want to just acknowledge, a few people here at the health department who helped me with preparing for the talk today. Dr. Anjali Talwalkar, who's the Senior Deputy Director, Nestor Rocha, who's the Director of Prevention, and Leah Varga, who's the HIV Services Planner. They represent a much larger team, but I think, we're still here. We're still doing the work that needs to be done. Community members have been at the table, supportive, and also trying to give recommendations to the health department. So I think that's been really critical as well. And I also see that there's a lot of support for ending the epidemic at the national level, both from the CDC, HRSA, the White House administration. They haven't totally forgotten about the field. And I think that's a really good thing to carry forward into the future.
Wonderful. Well, I'm inspired by each of you. You give me hope. Thank you for taking time with us. It really exceeded my expectations in terms of the ground that we would cover during this 1 hour of looking back on HIV and thinking forward. But I really like the last point that you made, Polly, and just the idea that HIV has learned from partnership with public health, medicine, community, and addressing the needs of those who are most marginalized in society. And I just hope that we take those lessons and really apply them to this current moment. And it's heartening to hear the leaders who have been leaders in HIV also talking about their successes. You three I'm thinking of, and just how we're using it in the current moment. So it's very inspiring, and I hope we've inspired some of our audience members to go into public health or community engagement or something like that, to continue the movement, as Marcia said. I want to give also special thanks to Marcia for your eloquent words and really reminding us of the importance of inclusiveness and engagement and looking back to move forward. Thank you. Allison, do we have any questions? I don't see any from my end, but if the audience has any questions, now would be a good time, because we have just about 5 minutes left.
While we're waiting for questions from them, can I just jump in? And I want to thank you, Audrey, for raising up community-based organizations. I mean, I think that, and I know from my experiences in working with them, that they provide such a valuable service. I mean, they really take people in as they are, and help to care for them, help to navigate them through, what can be very difficult terrain. So, and I hope the funding continues for them. And I think we should be very thankful for them. I've been very disturbed that, some of them have fallen by the wayside because of lack of funding. And I just hope that we continue to appreciate the role that they play still in helping us to get people healthy and well and feeling good. So thanks for doing that.
Yeah, and I think they've also benefited from telemedicine, right? And having services reimbursed in the current climate. So hopefully we can continue with that as well. Well, I don't see any questions, but I assume that just means we answered all of them. I want to thank you again, Audrey, Rupali, and Marcia. Thank you so much for joining us today. It's been a pleasure to be in community with you. And best of luck to each of you on your endeavors. And oh, I see one comment here. And best of luck to all of you who are HIV researchers and COVID researchers out there in the audience. We'd love to hear from you what you thought about today's session and moving forward about your own engagement and current research. So thank you so much. Have a wonderful afternoon, everyone.
Thank you.
Thank you.
Thanks, everyone. Take care.